Good afternoon, and thanks, Danny, for the very generous introductions. And good afternoon to all. I'm happy to see all of you staying on all the way to the Saturday afternoon. I think Danny has already given a very good summary of what I've been doing. Let me just quickly run you through today's to introduce to you the National Center for Infectious Diseases and its role in the management of emerging infections. So I think the first questions many of us ask is that why Singapore needs a National Center for Infectious Diseases, and how is this building look like? What is the infrastructure? What is the core functions? And what are the key challenges that we have faced since the establishment of the National Center for Infectious Diseases? So I think to many of the Singaporeans, and perhaps in this region, this is not something unfamiliar to you. Over the past 1 to 2 decades or so, many of the countries experienced through multiple episodes of emerging infections. In Singapore, my first encounter with emerging infections, in fact, was Nipah in the year 1999. And ever since that, we never really ceased having the challenges from the emerging infection. And that is basically the reason why we need to have a state-of-the-art building, the National Center for Infectious Diseases. Although it's quite a new facility, a new center, but it's actually riding on very strong and long history of infectious disease in Singapore, starting off as the Middleton Hospital in the year 1907 and subsequently renamed as the Center for Communicable Disease Center, and subsequently we moved into the new building that is a National Center for Infectious Diseases. A little bit more introductions in terms of the role and purpose of NCID. Now, it is designed to strengthen Singapore's capacity and capability in infectious diseases and outbreak-related prevention, surveillance, clinical management, outbreak readiness, and response. And in addition to that, it is rather unusual. It's a unique way of integrating clinical management to public health functions together with research, training, educations, plus community outreach as one of the key components to get the community involved in the management of infectious disease, particularly in the prevention. So the entire building is 330 beds, purpose-built facilities, and with full suites medical facilities. So in other words, with isolation ward facilities, with ICU, with a very special high-level isolation units, completed with imaging facilities, CT scanner, and all the way down to operating theatre as well as mortuary. Now the building itself, the design based on a few key principles. The first is to look at the capacity and scalability, and we look into the infrastructure capability, convertibility during peacetime, where we no need to deal with outbreak, and connectivities of how it connect up with general hospital as well as the academic center. The most important thing is the last point. We want to ensure that all the users in these facilities are safe. Just quickly showing you some of the photos of NCID. We have the outpatient facilities, and in there we have a huge screening center, high-level isolation units, isolation wards in the patient care area, 3 laboratories, including the National Public Health Laboratory, a research laboratory, as well as 1 clinical service diagnostic laboratory. Now, this is a closer look in terms of the patient ward. You can see that there's isolation wards, there is negative pressure with an anteroom, and a huge screening center. I would also like to introduce to you that if you do have the interest to learn more about NCID infrastructure, as well as role and functions, do feel free to look at the NCID corporate video, as well as a corporate video showing you high-level isolation pathogens units. And this is a very specific unit that we built because of the challenge that we face in other parts of the world, that is the dealing with the Ebola. Now, coming back into the integrated functions, this is how we look at ourselves. The clinical services, where we take care of clinical cases that include HIV cases. And these particular clinical units give us the ability to be able to handle clinical care provisions during outbreak. In addition to that, the public health units consist of the National Public Health Laboratory, the National Public Health Epidemiology Unit, 2 national programs, the HIV program as well as tuberculosis program. The next big components is what we place a lot more emphasis today. I will talk a little bit more on the output. That is the infectious disease research and training, where this is research units where we became the anchoring unit supporting NCID research against the COVID-19. It is also served as the national level training educations as well as community outreach. Now, this was actually before we started operating NCID. No, this was our conceptual plan of how we put all these elements together under one roof. So the key elements of clinical care, taking care of patients in inpatient as well as outpatients. Now, how then we flow the information and data to the epidemiology analytic units for them to be able to make sense out of the clinical informations, as well as the ability to flow the sample to the 3 laboratories, the National Public Health Laboratory, the Research Laboratory, as well as the Service Laboratory. Now, IDRTO, which is what I mentioned earlier on, the Research and Training Office, in fact, play a significant role during the COVID-19 outbreak in terms of the outbreak research. So, a very quick look at the NCID. We're facing the emerging infection challenges. We completed the migrations from the old Communicable Disease Center. As you can see from here, many of us left with a very fond memory of CDC. We completed the entire migration process by May 2019. So we moved into the new building, which is the National Center for Infectious Diseases. And the first thing we met was a small measles outbreak in Singapore. That was in June 2019. And we thought that it was quite a good exercise. And before we could finish that exercise almost back to back, we received the first case of monkeypox in Asia as well as in Singapore. And the official opening of the center was September 2019. So even before we officially opened the center, we had already faced 2 challenges in terms of emerging and re-emerging infectious diseases. And needless to say, I think most of us, COVID-19 arrived in Singapore in January 2020. Now, this is just a quick show to you in terms of our first challenge of measles. We had to open up the screening center, which is a huge space. When we designed the space, many people ask us, will you ever get to use the space? It's just too huge. But soon after moving in, we realized that the place already open to have a mass screening of then the migrant workers with the outbreak of measles. So we screened hundreds of cases within a very short period of time to determine whether or not they could have immunity against measles and allowed some of them to go through the vaccination. Now, quickly after that, as I mentioned earlier on, back to back, we received the first case of monkeypox in Singapore. Now, interestingly, this is patients who came from overseas, came to Singapore for a business workshop. He felt unwell and he isolated himself in a hotel room. And his friend did not see him for a few days and called for ambulance and sent him over to Tan Tock Seng Hospital Emergency Department. And from there, the patient was then admitted directly into NCID's negative isolation facilities. And with that, we could quickly make a clinical assessment, collect his clinical sample, send it over to infectious disease MPHL, National Public Health Laboratory, who has the capability to identify unusual pathogens. And that indeed had happened within a very short period of time. PCR showed positive, and we sent the specimens over to another lab using different primer. Again, both labs concurred. And one last thing was that we are able to look through the electron microscope to look and confirm that indeed that was a case of monkeypox. And we put all these activities together within a short period of 30 hours. And again, this is a test of our concept of how we hope and to put together the integrated functions under one roof. And we thought that at that point in time, we were quite happy that at least, we know that the infrastructures we built to respond to outbreak had worked, and the integration concept had also supported us through the very first challenge of the first monkeypox in Singapore. So we thought that at least we can have some rest, but indeed that wasn't the case. Soon after that, 4 months after NCID's official opening, we received the very first case of COVID-19 in Singapore. So this is just to show you 9 months after the encountering with the COVID-19, myself and Sean, who is also in the audience, subsequent speaker, we decided to reflect on what we have learned over the past 9 months with regards to COVID-19. And we thought that a few keywords that I will share here. First of all is to be flexible, and I think it's extremely important for the fact that there is almost like daily changes in the policy, in the workflow, and we just have to stay very connected and be flexible to be able to change to situational changes, to be able to scale up the entire response and activities. By doing so, we need to generate knowledge because that will enable us to have an evidence-based policy and management. The last one I would say is extremely important in terms of networking, and networking needs to be done during peacetime and to be activated during outbreak. And indeed, that had happened. I still remember that during that period of time, one of our keynote speakers who spoke on the bat virus, he had a very close contact with the Wuhan Viral Institutes. And from various different networks, we managed to understand that it's very likely that at that point in time, COVID-19 was caused by a coronavirus. And what we have done in Singapore is to look very closely in terms of the information and ask ourselves whether we can have a test available to be able to detect the first case of COVID-19 if it were to arrive in Singapore. And that kind of ability, in fact, gave us the ability to detect the first case on the 23rd January 2020 in Singapore. And also because of the inbuilt capability, we were able to admit patients and be able to collect adequate clinical samples for the lab to be able to do the test and analysis. And this is the first 18 cases that we published in JAMA. In fact, this has changed the way we look at COVID-19's response, which is very different from from SARS in the year 2003. During the year 2003, Singapore was hit quite badly with SARS-CoV-1. So we thought that perhaps the characteristic of the two viruses should not be too much of a difference, but actually that wasn't the case. When we received the laboratory information, when we started to analyze it with MPH-EU, we realized it's just the opposite. The virus was excreted in larger quantity during the early phase of clinical illness. And that prompted us to understand that prevention strategies cannot be exactly the same as what we had used in the year 2003 against SARS-CoV-1. And it was extremely new conditions to us. We have to look around, have our own data, put together our own evidence. Now this is I would say the first time that we put together this clinical course, and this has guided us in terms of the clinical management. We realized that round about week 2 or so of the clinical illness, that is the pneumonia phase, and that is a phase that we really have to look out for patients with hypoxemia. And once they pass the phase 2 of the pulmonary phase, they'll start to go into recovery phase. In addition, we map out the virus shedding patterns as well as the antibodies level over the entire time course. And I'm very, very proud that we put together this the clinical course to be able to show it to the clinicians as well as the practicing doctors on the ground in terms of the clinical course of COVID-19. I mentioned earlier on about scalability, which is infrastructure. Although NCID was built up to 330 beds, we could have the ability to put in more beds. And indeed, during the height of the COVID-19 last year, we scaled it up 4 times more than what we could cope. And in addition to that, we have to have tentages to expand our ability to screen the cases at the screening center. And scalability is one of the key important things as we need to deal with an unprecedented number of COVID-19 cases that was actually beyond our original concept and design. And during that period, it was a large outbreak that required many of the cases to be isolated in care facilities. So in addition to NCID, many of the public healthcare hospitals were also involved, including a very quick build-up of the community facilities care facilities. So you can see from here, hundreds and thousands of beds were then put up to be able to accommodate and isolate all the COVID cases in Singapore. Now, I just want to quickly touch point here in terms of the role of NCID and how we play the role to support MOH with evidence and to be able to have the right siting of care of the COVID-19 cases. Now, last year, we were still isolate every single case of a PCR positive SARS-CoV-2 cases or COVID cases, and we put them into different care setting to be able to cope with this huge number of cases. And those decisions or policies in terms of how we take care of the patients, in fact, evidence-based from the clinical informations and clinical studies provided by NCID. And a lot of community activities went on. Some of my colleagues here involved a lot in the community services, where they went down to look at the setup of the isolation facilities in the community, as well as providing training and educations on the ground. Well, life goes on. We had a short period of quiescence of COVID-19 cases, but since then, since April last year, COVID returned with the Delta variant, and indeed gave us quite a fair bit of a challenge. And that was the time when we celebrated our second anniversary, celebrated during the time when COVID or Delta variants was really going up. Here, I would like to show you one video, and I think this video will speak volume in terms of the things that we had done over the past 1 year. I hope it works. The National Center for Infectious Diseases has been at the forefront of the fight against COVID-19. The transmissions of SARS-CoV-2 was brought under control through a coordinated national effort. That allowed us to return to providing routine care while maintaining our readiness to surge. Vaccines became available, but the fight continues as we now face the formidable Delta variant.
The integrated approach of NCID is key to understand the virus's biological and clinical characteristics. With the rise of
became available, but the fight continues as we now face the formidable Delta variant.
The integrated approach of NCID is key to understand the virus's biological and clinical characteristics. With the rise of community transmission, we needed to study epidemiological linkages, identify risk factors of infection, and analyze data to provide evidence for progression of illness. We provided local evidence that vaccines can reduce the risk of severe illness regardless of age or pre-existing chronic conditions. There's still much work.
The National Center for Infectious Diseases has been at the forefront of the fight against COVID-19. The transmissions of SARS-CoV-2 was brought under control through a coordinated national effort. That allowed us to return to providing routine care while maintaining our readiness to surge. Vaccines became available, but the fight continues as we now face the formidable Delta variant.
The integrated approach of NCID is key to understand the virus's biological and clinical characteristics. With the rise of community transmission, we needed to study epidemiological linkages, identify risk factors of infection, and analyze data to provide evidence for progression of illness. We provided local evidence that vaccines can reduce the risk of severe illness regardless of age or pre-existing chronic conditions. There's still much work to be done, and we are all racing to understand more about this virus.
NPHL has expanded our range of testing objectives and methods to study vaccine response and variants. We detect antibodies for past infections, monitor vaccine response, and use virus gene sequencing to determine how the virus is transmitted. We continue to assist in public health investigations and serve as a reference laboratory for the World Health Organization. It has been challenging but interesting as we have a chance to study this virus like never before.
Our research efforts have only been possible with the support of our patients, an excellent research team, and dedicated collaborators. Recent work has focused on studying vaccine effectiveness and understanding the immune response to vaccination. We were one of the first to report that vaccinated people clear the virus faster than unvaccinated people, and that vaccinations protect against severe illness from the Delta variant. While our work is ongoing, this local data has helped inform our public policy and treatment guidelines.
Our understanding of variants in vaccines became the backbone of our clinical response. We saw more community infections across various groups with varying severity depending on vaccination status and age. Through our unit's combined efforts, we contributed our research and operational data to inform admission and discharge policies. This resulted in right siting of care and informed discharge plans for vaccinated patients, streamlining the use of hospital resources and allowing patients to return to the community quickly and safely.
Our experience from 2020 has made us more prepared and better equipped. Many patients who came in with pre-morbid conditions require complex care, so we stepped up and expanded our skill set. And because they were isolated from their families, we found ways for them to connect safely. Throughout the many months, the nursing team continuously supported and took care of each other every step of the way.
NCID continues to play an active role in the battle against COVID-19, yet not neglecting other infectious diseases. We continue on with the national programs on HIV, tuberculosis, and antimicrobial resistance, and engaging the community on the importance of vaccination. It has been a long journey for us, but our staff have remained resilient, selfless, strong, trusted, and united. I'm heartened and proud that everyone has stepped up to fight this virus. We will live up to our mission to protect the people of Singapore from infectious diseases. Okay, so I hope you enjoyed the video. I'm going to fast forward a lot more because of the limitation of time. None of this work can happen without a very good network as well as a very good platform. This is a platform we call Protex. They are able to support multi-prong of the research. So this is where we are. You can see Singapore in the red line. We are now currently still having quite a sizable number of COVID-19 cases, predominantly by Delta, and that is also because of the assistance of National Public Health Laboratory in partnership with Ncid. We are able to look into submitting the sequence and to be able to contribute to the entire global surveillance. Now, this is just to show you those in red are Delta. So you can see Singapore is just basically all Delta, almost close to 100% of them, the cases. Now, just quickly showing you some of the key findings. So you can look at this graph here. The top red line shows you the Delta variant, and the green line shows you the wild type. So you can see from here that, in fact, indeed, all three VOCs that we experienced in Singapore, all of them had a much higher virus secretions volume in the respiratory tract compared to the wild type. In particular, the Delta tends to have a much higher quantity of virus being secreted in the respiratory tract and secreted for a much longer period of time. And when we look at the vaccine breakthrough cases, we realize that for the vaccine breakthrough cases, they tend to clear the virus much earlier. And this is one of the key findings that we contribute to the scientific knowledge internationally. Now, let me just quickly fast forward to show you that this is another studies together with the Professor Wong Ling Fa, showing the post-infection, natural infections, the waning of antibodies using CPAS as the testing methods. Similarly, when we look at the vaccine cohorts, we also realized that the antibodies level wane over a period of time using either the CPAS study, which is the surrogate VNT test, or looking into the S antibodies. But what is more important here is not only the waning of antibodies, we also saw a waning of the viral effectiveness against infections, although the vaccine effectiveness against serious infections is still relatively intact. And that's the reason why we are seeing an increasing number or increasing proportions of cases with the vaccine breakthrough, COVID-19 in Singapore. At the same time, we also realized that when we did the cytokine study looking at inflammatory markers, individuals with post-vaccine infections tends to have a lower level of pro-inflammatory markers. May be a good size. In other words, they may have less of the tissue damages compared to the natural infections before they received the vaccines or before vaccines became available. And this is where we are in Singapore. We have close to 86% of the entire populations receive 2 doses of COVID-19 vaccine. And we also started in somewhere around September, started the booster program. And currently we have more than 500,000 of individuals being boosted with the 3rd dose. Now, this is a very detailed study published in Science showing the durability of the immune response, not only the antibodies response, but also the cellular response seems to be durable in cases where we have past infections with vaccinations, as well as patients who rely mainly on vaccinations. So there we go. I was trying to reflect on the keynote lecture by Professor David Heyman. How do we then look at the utility of COVID-19 vaccines? Do we go for elimination, which is what we use for ages against measles, where we vaccinate the entire populations, and using the vaccines to prevent infections or prevent clinical illness? Or, we may have a strategies of living with COVID-19, allowing some of the individuals who had 2 doses of vaccine, allow them to have infections, allow them to have a natural immunity, so to speak, to broaden the immune response. Or we have a slightly different way of compositions. We protect the vulnerable, we protect the older patients, and we allow the younger people to go ahead and to get the infections. So I think those are the strategies in Singapore situations. We have to think ahead what will be the best that we can be able to achieve a low mortality of COVID-19 in Singapore. But personally, I feel that regardless of what vaccine strategies we are using at the current point, the non-pharmaceutical public health interventions cannot be compromised. Now, we are also very thankful for one of my colleagues who is a speaker later on, who put together the National COVID-19 Therapeutic Guidelines. And it's a very active work group, I must say, because there are so many new agents currently being made available and so many different trials trialing at different phase of COVID-19. They have made significant results that we need to have a relook in terms of how we utilize these therapeutic agents at different time points. So I do believe that this will be a really moving targets and also a living documents that's being put together by the group in Ncid. Now, just quickly round up in terms of the current situations in Singapore, in terms of the number of cases, we have close to 230,000 cases, and of that we have 548 fatal cases. So the case fatality rate in Singapore remains to be extremely low. It's one of the lowest in the entire world. And in terms of how do we then accommodate this large number of cases, currently we have 70% or more of these individuals are being cared for at home. and a proportion of them are being cared for in the isolation facilities, and about 1,000 over in the acute care hospital. And NCID has been averaging around 20 to 30% of all these acute cases being managed in NCID. I just want to again emphasize in terms of network, and this is one of the informal regional network that we put together to share our own experience with regards to COVID-19. I look forward to many of you, if you do have an interest, to join us in these informal discussions. And lastly, I just want to thank all our people. Without these people behind NCID, we will never be able to walk the journey to where we are today. So I would like to thank all the audience as well as all my co-workers in NCID. Thank you.